Assalamu alaikum. Good afternoon, everybody. Thank you, Dr. Meher, and thanks for Dr. Wael and Emirates Society of Internal Medicine to invite me for this eminent evening among our eminent speakers. As Dr. Meher kindly mentioned, my topic for this evening, for this afternoon, about the standard of care in diabetes, the summary revision of 2025. Actually, this is the more than 300 summary page issued on annual basis by ADA, American Diabetes Association. I did my best to summarize it in a few slides. And I know the time frame is very tiny, so I will try to be customized to the target and without compromising the scientific content or the benefit for the lectures. As we know, it's composed of 17 sections ranging from improving care for the diabetic patient and how the diagnosis, classification of diabetes, prevention or delay for the diabetes, comprehensive medical evaluation, facilitating positive health care, glycemic goals, any update for the diabetes technology, obesity and weight management, pharmacological approach for the anti-hyperglycemic medications available, and the cardiovascular, renal, retinopathy, neuropathy, older patient, children and adolescents, and the management of diabetes in pregnancy and in hospitals, and finally the diabetes advocacy. This is the official link or the official website where we can get the PDF form for the 2025 standard of diabetes summary. I have two sections here to mention. I have a quick few slides for the key highlights for the 2025 standard of diabetes, and later on we will go for some details if the time allow me. So the 2025 ADA guidelines continue to emphasize on the individualized patient or centered patient approach, empowering the terminology and the consideration for social determinants. It's advised now to avoid the term diabetic patient. We can instead use the term of person with diabetes. And as we know from our attendance for last lectures, we have a new terminology or emerging terminology. Either it's a cardio-renal metabolic disease or cardiovascular kidney metabolic disease. As we know, there is interrelated systems between the heart, liver, pancreas, adipose tissue, and the kidney. So they try to merge it in cardio-renal metabolic system. Of course, with a weight-based approach is very important to manage, and team-based care. Of course, no one only alone can manage the diabetes. However, it's a team management, so they are emphasizing for that. And also we have a section regarding the continuous glucose monitoring. As we know, for many decades, we use the glucometer and random fasting glycosylated hemoglobin. However, now there is emerging rule for the continuous glucose monitoring beyond just patient for using insulin. We used before, even for approvals to get continuous glucose monitoring to be patient with type 1 diabetes or patient on insulin. However, there is a new rule also, not only for these categories for patient, we still need continuous glucose monitoring for add-on category for patients. The algorithm continue to be aligned with European Association for Studying Diabetes and American Association for Clinical Endocrinologists and ADA. And there is endorsement also from the other societies like the American Society for Bone and Mineral, the Obesity Society, American College of Cardiology, SSC, and new in this year in the standard diabetes, they add the American Geriatric Society to be also in the section 13, who is dealing with the older patient. Also, they are highlighting the type 1 diabetes update about the antibody-based screening for specifically pre-symptomatic type 1 diabetic patients, and for this category for a patient, we can use the islet cell autoantibodies for diagnosis, and also we have now approved tibulizumab. This is used for pre-symptomatic type 1 diabetic patient as a prophylaxis or a precautions to develop diabetes in the future. Who should be eligible or candidate for such new medications? All first-degree relatives for patients with type 1 diabetes and newly diagnosed adults, and based on the consensus or in team decision. And we have also a new recommendation for persons at a risk of DKA. They should avoid cannabis because it's lead to the risk for hyperemesis or persistent vomiting, which is a prone factor to or specific factor to develop the DKA. This is the known 3 stages for type 1 diabetes. We have stage 1 and 2, which are usually pre-symptomatic, and this is below the how can we make the diagnosis by the antibodies. And we have the stage 3, which is the overt diabetes type 1 with hyperglycemia, and also the markers for the diagnosis. Also continuing in the 2025 for the update for the medications, GLP-1 receptor agonist also still they have a big role in the management for diabetes. And we know for it was 2 or 3 years ago we suffered from some shortage in the supplementation for the GLP receptor agonist. So they were dealing with how to handle this shortage and what is the alternatives for that. Of course, there is still expanding role for the GLP-1 receptor agonist regarding the established atherosclerotic cardiovascular disease patient heart failure with preserved ejection fraction and the chronic kidney disease. We know 2 years ago that there is change in terminology regarding the fatty liver. Now the non-alcoholic fatty liver disease, it's substituted by metabolic dysfunction associated steatotic liver disease, which is more logic, and it makes sense because not all patients non-alcoholic will suffer from fatty liver, so they change to metabolic dysfunction associated steatotic liver disease. And also the NASH, the non-alcoholic steatohepatitis, which the term used for many years, it's now substituted by metabolic dysfunction associated steatohepatitis. What are the medications available now for liver steatosis? We have diabetes medication which could help, like the GLP-1 receptor agonist and the bioglitazones. However, this is still in trial. We can use either single or combination for them. We have an emerging new medication dedicated only for fatty liver disease, especially if we have liver stiffness measurement of F2 to F3. This is named resmetirom. Resmetirom, this is a thyroid hormone receptor beta agonist approved for metabolic associated steatotic liver disease. And later, when we will take sections in little details, we can see that it's dedicated only for the patient by the elastography for F2 to F3. The screening update, still we are emphasizing for the first visit for our patient for the disability in persons with diabetes. We can check for peripheral artery disease, and this can be easily done in the assessment room by our trained nurse about the ankle brachial index. And this should be deployed for all our persons with diabetes, especially in the initial visit. And later on, we can make it on a regular basis once we are suspected such disability. For sure, male and female health, we can continue screening for hypogonadism and for any genitourinary symptoms, especially if we are using SGLT2 inhibitors. As we know, it's one of the adverse events that could cause some mycotic infection. Of course, persons with diabetes and their caregivers could suffer from some anxiety, depression, some worry about their disease future, so they should receive some psychological support. Also, we have update for the fasting. The fasting, it's very easy. We are following the International Diabetes Federation for Diabetes and Ramadan, and we have already either one paper printed a chart regarding how to stratify the risk for the fasting during Ramadan, or it's already a calculated website. Mid-calc, we can enter the patient figures here or data, then we can calculate the risk. And this is a very common question we will face in the coming Ramadan: who should fast and who should not be fast, and who should fast with precautions. This is the 17 sections for the diabetes care. Section number 1, about the improving care to promote the use of interprofessional teams and the quality improvement initiatives, and continue to include information on the online platform to support behavior change and well-being. Section 2, for the diagnosis, still we have the same 4 categories for diabetes: type 1, type 2, diabetes due to other causes, and gestational diabetes, and the diagnosis is still the same regarding the glycosylated hemoglobin, fasting sugar, and postprandial sugar. This is a quick consideration regarding when we use glucose and when we can use HbA1c. For sure, it will depend on the cost and the simplicity, on the fasting, on the availability, and the test interference. A new recommendation, as we mentioned earlier, regarding the patient with type 1 diabetes, for the pre-symptomatic specifically, should be screened by the proper antibodies, and we can give them the tezolizumab regarding as a prophylaxis to be developed over type 1 diabetes. The diagnosis and classification also, who should be screening for diabetes. They stated that all adults above 35 should be screened, or overweight or obese patient or BMI above 25 should be screened. And if the results are normal, we can follow every 3 years. And if the HbA1c between 5.7 to 6.4, which is increased risk of diabetes or pre-diabetes, we can screen every 3 years. We can check yearly, annual basis. Youth also screen who are overweight, and there is some patient, as we know, could be on medication that can cause hyperglycemia, like steroids, thiazide, and the antiretroviral medications and the antipsychotic. Something to emphasize, as we emphasize on the lifestyle modification, diet, exercise, and weight loss, also the sleep is a central component right now included in the 2025 summary for diabetes. And the care of goal, of course, 3 to 7% weight loss, up to 15% of weight loss could make remission for the type 2 diabetes. And very, very new and added about in the discussion for 2025 that vitamin D could prevent type 2 diabetes. And Dr. Hassan, my colleague, in the next presentation, he will show us the rule for the vitamin D, the doses, and the evidence for that. And it's published already in EDA that low vitamin D may contribute to the insulin resistance. For the prevention or delay of diabetes, drug therapy is still the same. We can consider anti-hyperglycemic to reduce progression of diabetes in high risk. Metformin still play a pivotal role in 25 to 60 years old patient with BMI above 35 or fasting glucose above 110. Bioglitazone still there is a role if in the reduction in the risk of stroke and myocardial infarction. However, we should balance between the risk of the bioglitazone regarding the weight gain, edema, and the fractures. The bone health, this is emphasized for when we can start making the bone density imaging above 65 or the other risk factors. Recommended calcium intake 1,000 to 1,020 per day. And there is also add-on beyond the care for the bone and the immunization, also the dental care. Also, as we advise our patient regarding the ophthalmology, neurology, and the heart assessment, also there is a dental care which should be also be on annual. This is the liver status regarding the metabolically associated liver disease. We have also a mid-calc score regarding the fibrosis score. This fibrosis score for patient with fatty liver disease. If the fibrosis score index, we enter the liver enzymes, age, and the platelet count. If it's more than 1.4, so we can go for liver stiffness measurement. And if it's above 8 kilopascal, we can refer to a hepatologist, or if it's less than, we can follow the lifestyle modification. This is the rule for resmetirom, the new medication for the fatty liver disease. It's only for if the patient has between F2 and F3. The DSMS, which is Diabetes Self-Management Education and Support, this is facilitating positive health behavior for our diabetic patients. This is the dietary recommendation. For the dietary recommendation, we have a new title named chrononutrition. Chrononutrition, this is eating specific diet in a specific time of the day, and it is emerging or will be coming era. Still, there is conditioning recommendation for the non-nutritive sweeteners over the traditional one. This is quick difference between the religious fasting and the intermittent fasting. Of course, the fixed duration and timing and the will be underlying who will continue for the intermittent fasting and the religious fasting. This is the same score calculator. The weight loss, as we mentioned, target goal between 3 to 5. However, if we achieve 15% weight reduction, we could make type 2 diabetes remission. This is quick difference between diabetic ketoacidosis and hyperosmolar non-ketotic, and this is the individualized hemoglobin A1c goals regarding the our patient, the older the patient and the higher risk of the patient, we can be tolerant regarding the HbA1c. Like if our patient is above 65 with risk of fall, risk of hypoglycemia, or severe debilitating disease, of course, we can at that time consider hemoglobin A1c between 7 to 7.5 is fine. Unfortunately, severely ill patient or terminally ill patient or admitted in long-term facility, we can consider HbA1c. There is no specific level for it. Even if it's above 7.5, it can be fine. The other sections later on, it's about 17 section. We only reach section number 6. There is about update regarding the medication. The update for the medication, nothing new apart from still emphasizing the role of GLP-1 receptor agonist regarding the cardio protection, renal protection, and if there is any contraindication for the SGLT2 receptor inhibitors. There is also a section regarding continuous glucose monitoring. They now not considering only for patient who is receiving insulin, but should be considered for patient who is at a risk of hypoglycemia or patient who is using multiple medications, because as we know, all guidelines and trials now, they are in the favor for the continuous glucose monitoring. There is another section for the cardio-renal protection. As we know, the eminent role for SGLT2 receptor inhibitors and GLP-1 receptor agonists in the cardiac and renal protection. Also, there is a section regarding the statins when we are using the statins, and section for the hypertriglyceridemia when to treat. And there is also regarding the patient in the hospital. Patient in the hospital, the target sugar should be between 140 to 180, and we should intervene for admitted patient when the sugar, random sugar start to be above 180. There is the section for the admitted patient, and finally there is some update regarding the inhaled and the for inhaled insulin beyond the injection, and finally there is some diabetes advocacy regarding if patients, person with diabetes living in a jail or some health sanatorium or some institutes to be managed. There is some new guidelines regarding how to manage. Thank you so much.